All right, we'll begin, and I'm sure we'll still have some people joining us momentarily. Hello and welcome. Good morning, good afternoon, good evening to everyone, depending on where you are around the world today. And thank you for joining us. Happy UHC Day 2022.
In English,
Could everyone please kindly mute yourselves? Thank you very much. Today, in recognition of UHC Day 2022, our team for Management Sciences from Health is convening policymakers and practitioners from around the world to discuss how high-quality, person-centered primary healthcare must be the foundation of achieving UHC and helping us all to drive forward towards achieving Sustainable Development Goal 3. As we approach the midpoint for achieving the SDGs, we know that we're in a perilous position. The past several years have been difficult. The pandemic, climate change, fiscal austerity, and growing inequities around the world threaten our progress to date and make us question if we will truly be able to achieve these global goals. The theme for UHC Day 2022 this year is to build the world we want, a healthy future for all. In the world we want, in the world I want, all people can access high-quality health services without financial hardship. Universal health coverage lifts people out of poverty, promotes the well-being of families and communities, protects people against public health crises, and moves us all towards the original goal of Alma Ata, health for all. So today we come together to ask, in honor of UHC Day, how can we build strong, person-centered primary healthcare systems as the foundation of UHC to drive forward towards achieving SDG 3? What are the global best practices? What are we learning from them? And how can we ensure that these experiential lessons are brought to bear as we approach 2030? Before we begin, a few logistical points. First and foremost, this webinar is being recorded, and we're pleased to offer simultaneous interpretation in both French and Spanish, in addition to my English, as well as closed captioning today. All participants, please need to select your preferred language, even if English is your preferred language, by clicking on the globe icon at the bottom of your Zoom screen. When you do click on that icon, you will see the option to choose English, French, or Spanish, and to mute the original audio if it is distracting you from hearing your language of choice. Once again, even for English speakers, it is important to do this so that you will know that Zoom will know that you prefer English when the language of interpretation is not English audio. In addition, you may also select if you would like to read closed captions during this session. You should see these captions automatically, but if not, you can select them by clicking on the icon at the bottom of your screen with 2 letter C's. If you wish to hide those captions later, please click the same icon again and select the hide subtitle option from the menu that appears. These captions are generated using an automatic feature in Zoom, so there may occasionally be errors for which we apologize. And unfortunately, today, those captions are only available in English, but the audio translation is available in 3 languages, which hopefully should work for most people. If you need technical support with any of this, please connect with my colleagues via the chat box, and people can private message you to help navigate the system. Having said that, as we go through the session today, we strongly encourage everyone to please engage with our speakers and ask questions via the chat. You can type your questions directly into the chat, and we will moderate on the back end. Please feel free to type in English, Spanish, or French. We will handle the translation. We will ensure after the speakers have an opportunity for opening remarks that there's ample time for discussion after our speakers give their opening remarks, and we will try to include and respond to as many comments and questions from the audience as we can. So please familiarize yourself now with the chat feature and perhaps experiment and say hello in the chat and tell us all where you're joining from today around the world. Now, without further ado, let's begin by introducing our 5 amazing panelists today. And I will be introducing them in the order in which they will be giving their opening remarks. And then we'll get started right after that. First and foremost, our first panelist will be Dr. Serge Raharison, who is the Chief of Party and leader for the Access program in Madagascar, which is an MSH-run USAID-funded program. Serge has over 30 years of experience in public health program implementation, design, and management. He graduated from the Medical School of Antananarivo in Madagascar and earned his master's degree from the London School of Hygiene and Tropical Medicine. He started his career as a frontline care provider in humanitarian crises and then gradually led the implementation of health and development initiatives with Médecins Sans Frontières, CARE, JSI, Chemonics, FHI 360, and several others. In the late 2000s, Serge was appointed by the government of Madagascar as the Secretary General of the Minister of Public Health, before moving ultimately to the US later on to join the USAID-funded Maternal Child Survival Program, MCSP, in Washington, D.C. In that role, he supported country programs in the DRC, Guinea, Rwanda, Mali, Liberia, and Haiti. And then in March of 2019, Serge returned back to his home in Madagascar to join our team at MSH and has been a leader of the Access program since that time. Our second speaker today will be Dr. Jeff Markuns, who is the Executive Director of the Primary Healthcare Performance Initiative. As the Executive Director, Jeff leads PHCPI, which is a global partnership between the Bill and Melinda Gates Foundation, the World Bank Group, the World Health Organization, UNICEF, the Global Fund, Ariadne Labs, and Results for Development. PHCPI focuses on strengthening primary healthcare measurement for improvement, but with a specific focus on low and middle income countries. As a practicing family doctor and faculty member at Boston University for over 2 decades, Jeff also founded the Health Professions Education Master's Program there and has deep experience in frontline primary healthcare and the human resource capacity building necessary to support its success. In addition to these other roles, Jeff is also the president for the North American region of WONCA, which is the World Organization of Family Doctors, and leads Boston University's Global Health Collaborative, in which role he supports successful long-term, both vertically and horizontally integrated development programs, promoting primary healthcare systems strengthening throughout Southeast Asia and in Lesotho in Southern Africa. Our third panelist today will be Rosemary Mburu, the Executive Director of WACI Health. Based in Nairobi, Kenya, Rosemary is a global health advocate and civil society leader working to create political will for improved health outcomes in Africa. Her areas of expertise include policy analysis, building political support for health outcomes, influencing decision-making processes, mobilizing civil society and community voices for action, and promoting good participatory practice in clinical trials. Rosemary has extensively worked on building and strengthening civil society and community organizing for health advocacy throughout Africa. She oversees the Civil Society Platform on Health in Africa, the Global Fund Advocates Network African Hub, and the Africa Free of New HIV Infections Network. She is a member of the Vaccine Advocacy Resource Group and is the Southern CSO representative on UHC 2030. Rosemary has published several peer-reviewed articles and blogs focusing on clinical trial ethics, investments in HIV prevention and research, and strengthening primary healthcare. She holds a master's in public health from Ohio University and a master's in business administration from Frostburg State University. Our fourth speaker will be Diana Frymus. Diana is the director of USAID's recently launched Accelerating Primary Healthcare Collaborative. The collaborative aims to better harness USAID global health programs and galvanize partnerships to accelerate progress while demonstrating measurable improvement in primary healthcare. She brings 15 years of work experience in the field of health workforce and health system strengthening, leading diverse teams in developing strategies and advancing more rigorous monitoring and use of data analytics for USAID and PEPFAR programs. Diana serves as the agency's technical lead for the Biden administration Global Health Worker Initiative. She has been the chair of multiple U.S. government and external working groups and was an inaugural co-chair of Health Systems Global CHW Community Health Worker Technical Working Group and the WHO's Health Data Collaborative Human Resources for Health Working Group. Diana received her master's in public health from Columbia University and is a former Peace Corps volunteer, where her work in Uganda to increase health worker engagement in person-centered care had a pivotal impact on the start of her career. And finally, our fifth panelist will be Peter Hansen, who is the head of research, results and learning at the Global Financing Facility for Women, Children, and Adolescents. In this role, Peter leads the GFF's results and learning workstream. Previously, Peter co-led Results for Development's health portfolio and served as the director of R4D's Health System Strengthening Accelerator. He also worked at the Global Fund, where he led a department responsible for accelerating the introduction and scale-up of innovations and ensuring scientific and technical quality of investments totaling nearly $4 billion per year in over 100 countries. Previously to that, he worked at Gavi, where he led the monitoring and evaluation function and investments in strengthening country data systems and capacity. So as you can see, we have a very exciting and impressive lineup of 5 speakers today. And as I mentioned, we'll be allocating quite a bit of time for discussion with the audience afterwards. So let's get started. We'll begin with Dr. Serge Raharison. Serge, you oversee the MSH-led USAID Access program in Madagascar. Access works alongside the Ministry of Public Health to accelerate sustainable health impacts for the Malagasy people. This program has has achieved sustained reductions in maternal and child mortality throughout 14 regions of the country, reaching over 17 million people. Access has had a strong focus on the provision of person-centered primary healthcare throughout its programs. So please tell us, why is person-centered primary healthcare such a crucial approach, both from the perspective of the Access Project as its leader and from your own perspective as a Malagasy health leader? Thank you.
Thank you very much, Dan. Dear colleagues, ladies and gentlemen, good afternoon, good evening, wherever you are. I am going to share to you the story of a young 18-year-old woman that got pregnant in a rural, remote village of Madagascar. Her father, was a peasant, and while he had a very limited education and access to resources was scarce, he made sure that his dear daughter completed all of required antenatal care visits at the health facility. Unfortunately, despite his efforts to anticipate and to plan, his daughter went into labor on a day where he was away from home. And when the delivery became imminent, decision was made somehow that the pregnant woman would not go to the health facility for the delivery. The courageous young woman went through a prolonged labor during days without any assistance from skilled birth attendants. I cannot pretend I know, I cannot pretend I understand or imagine how painful, how exhausting, and how emotionally draining such an experience can be. Only women who give birth can do that. And really respect to all mothers around the world. Then after those 3 days, a miracle happened. A young baby boy was born. Here, I can imagine how relieved she was, and I can imagine how full of joy she was. I know this is not a unique story. I know miracle happens every day, and mothers give birth in unbelievable conditions in our communities. Unfortunately, some of them don't make it. The only unique thing about this story is that that young mother, that young lady was my mother, and that the baby boy was me. And we both survived. I don't know by what miracle my mother and I survived that day. What I know is that I am in this business of public health with a mission that is to do my best that no pregnant woman, no newborn baby, no child, no adolescent, no one is left behind. That is essentially the heart of WHO's definition of universal health care. Universal health coverage. Let me read it. All people have access to the full range of quality health services they need, when and where they need them, without financial hardship. I love my job. I love what I do here at Access. In this project, I lead nearly 1,000 people towards that vision. To me, a person-centered primary health care is a simple concept. If you look closely at the 3 actors in my story, you will see number 1 is me. I didn't make any choice. I entirely relied on my family, on my surroundings, why I was born in such a conditions, and what we can do to all these babies that are born in these conditions. If you look at the second actor as my mother, in theory, she had the choice. She had the option to deliver the health facility, but she didn't. Had she underestimated the risk? Did she have the decision-making power to do so? And or did she have the means to make her decision happen? And third is my grandfather. Culturally, he had the power and the conviction to make the right decision. And I know if he was there that day, things might have happened differently. How did he fail to tell others what to do? My late grandfather is my hero. He used to be a Red Cross volunteer. I equate him to the community health workers that we see every day in our job, in our programs, in our projects. It looks like my grandfather missed my day of birth, but he was able to catch up later. He made sure that I got all the vaccinations I needed. He got me to the health facility every time I got sick. And moreover, he made sure that I get the education, the good education that I had. And that's the reason why I'm here with you today, because I followed his footsteps. We have thousands, if not millions, of champions like my grandfather. It's our job to empower them and to make sure that the real person-centered primary health care happens. Thank you very much. Thank you, Dan.
Thank you, Serge. Every time I hear that story, it's gut-wrenching. I'm glad that your mother and you both survived. Thank you for starting us with such a grounding story. Jeff Markuns, our next panelist. Jeff, as the executive director of PHCPI, since its inception, PHCPI has led pioneering works to help further define and comprehensively measure critical aspects of primary healthcare. It has literally built the field. As PHCPI Global Partnership comes to a conclusion at the end of this year, I'd like to ask you to reflect on both the successes to date and perhaps more importantly, the work still to come. How can participants and the panelists, how can all of us on today's call help to take that work forward for the future? Thank you.
Thanks, Dan. It's great to reconnect and get to talk together again about PHC. As you mentioned, it's a really pivotal moment for all of us at PHCPI as we're moving to wind down our formal operations as a global partnership. In parallel, our core partner organizations, including the World Bank, WHO, UNICEF, Global Fund, and the Gates Foundation, as well as RNA Labs and R4D, all stand ready to take the work forward into 2023 and beyond. You know, we've been reflecting on the legacy of PHCPI over the last year, and we're really incredibly proud of how far we've come since 2015. Three successes stand out in particular: PHC measurement, PHC advocacy, and organizational commitment. First and foremost, there is now global agreement that it's possible to define and measure primary healthcare in a rigorous and comprehensive way, which is absolutely critical for tracking progress, targeting investments, and holding ourselves accountable. We began with developing a new conceptual framework for primary healthcare that tried to shed light on what's most critical in frontline service delivery. But when we sought globally comparable data sources for the framework, we found just massive data gaps. These gaps then inspired us to create new data collection tools, such as the progression model developed by yourself and RNA Labs, and seek out alternative country-based data sources, ultimately leading to PHCPI's flagship product, the PHC Vital Signs Profile, or VSP. A clear, understandable snapshot of primary healthcare performance without sacrificing necessary complexity. We've now partnered with over 30 countries to develop a VSP organized around key pillars of financing, capacity, performance, and equity. Each pillar brought something new to the table. The financing pillar utilized first ever PHC financing data released by WHO utilizing a standardized global approach. For capacity, we developed a new way for countries to rigorously assess their systems with qualitative and quantitative data. For performance, we identified ways to measure quality in core primary care functions: frontline access, comprehensiveness, continuity, coordination, and patient-centeredness, which I know, Dan, you and I both agree are essential to understanding the successful performance of frontline healthcare. And we highlighted inequities from multiple angles as a critical outcome because strong PHC should reduce these gaps on all fronts. All of this helped lay the groundwork for the first ever globally endorsed primary healthcare measurement framework and indicators, recently launched by WHO and UNICEF for measuring and monitoring PHC. Prior to the partnership, an agreement like this was inconceivable. Now, our core partners are ready to use these tools to support countries at both national and subnational levels. Second, after measurement, I'm most proud of the partnership's work in mobilizing practitioners and advocates from our communities of practice, developed in partnership with the JLN and engaging a range of countries, to our coalition of over 125 allies improving PHC, who've recently rallied more than 220 groups to push a greater focus on PHC in upcoming high-level meetings. And last but not least, throughout PHCPI's journey, our core partners themselves have all increased their investments in primary healthcare, and their commitment is stronger than ever as we look ahead to the future. As PHCPI concludes in the wake of these successes, we all agree that our collective work, cooperation, and advocacy on PHC cannot end. And so I really appreciate your question about what we can all do in carrying this work further forward. First, we still badly need to prioritize collecting and reporting more data on primary healthcare. While we've laid out the blueprint for better measurement, what matters now is uptake and data collection. For example, we need better data on financing, including precisely where money is going and what kind of returns countries are getting on these investments. The current measures we have are simply too broad to effectively inform investments, and we need to do better. We also need improved ways to measure capacity, such as incorporating maturity model strategies like the PHC progression model and upcoming collection tools. Perhaps most importantly, we desperately need more data on quality, and especially the core primary care functions that have been proven time and again to be the special sauce that makes PHC service delivery as effective as it is in reducing overall morbidity and mortality. In our work with countries to date, only 40% of all our quality indicators had any data at all. Finally, equity must be front and center in how we evaluate progress on PHC. And that means transparently reporting on a range of inequities so that we can target investments to leave no one behind. In addition, we need committed leaders to increase strategic investments in integrated, equitable, and comprehensive PHC across the lifespan that are unrestricted by age, gender, disease, or organ system. And as advocates, we also can't stop making the value case for strong primary healthcare or take any of this progress for granted. If we want to be prepared to deal with the next crisis, we need strong, equitable foundations for health systems that give people quality primary healthcare they want and trust. Ultimately, as we like to say, primary healthcare is primary for a reason. As we enter 2023, it's officially time to set aside the myth that primary healthcare is too complex, that it's too expensive, or too ambitious to act on. It is measurable, it's achievable, it's affordable, and it's the absolute single best investment to operationalize global commitments to universal health coverage, pandemic preparedness, and health for all. Now that we know more about how to define and measure primary healthcare with a growing number of leaders taking up the mantle of PHC and a proven playbook for how to get this done, there's a deal of opportunity for us to channel this momentum into meaningful changes for people and communities around the world. Dan, I really hope this work by you and everyone involved with PHCPI will have inspired all of us to make the most of it.
Thank you, Jeff. And I'd just like to personally, given that I am the moderator and I have the ability to make personal comments, I'd just like to personally amplify your final comment that it is mythology. It has to be something of the past. It's not too complex. It's not too expensive, and quite the opposite. It has to be our obligation. Otherwise, we're not going to succeed in the global goals. Thank you, Jeff.
Hear, hear.
Moving on. Our next panelist, Rosemary. Rosemary, you have an enormous amount of experience in advocacy and civil society building mechanisms. WACI is an African regional advocacy organization and also partners with us at MSH to co-host the Civil Society Engagement Mechanism of UHC 2030. In your work, how have you seen communities being engaged in designing primary healthcare systems that are responsive to their needs and to ensure that no one is left behind on the road to UHC? Excuse me. How does UHC-focused advocacy, as led by the Civil Society Engagement Mechanism of UHC 2030 and its partners, advance investments in primary healthcare and help to achieve this year's UHC Day theme of building the world that we want?
Thank you very much, Dan. Good morning, good afternoon, dear colleagues. I'm coming to you from Kigali, where the Conference on Public Health in Africa is happening. And very much aligns to this conversation here today, what we are hearing here in the conference, especially when we talk about pandemic prevention, preparedness, and response, is really about ensuring that we have communities on board. And I think there's even a running theme that is going on saying not without communities, and that we will not have strong health systems, we will not adequately be able to prevent and prepare for pandemics and even respond to pandemics without adequate engagement and involvement and leadership of communities. And to your point, in terms of how we have seen communities being engaged in designing primary health care, I think the first thing is to say that a lot countries have different structures and modalities of how communities are involved in national decision-making processes or in national platforms that provide leadership on how health systems are designed. And there are different ways how communities and civil society are included into that, and it varies from country to country. We have seen some of the countries including communities and civil society in technical working groups that advise, the Ministry of Health on, systems that are responsive to people's needs. We have seen other countries that have national platforms that are multi-stakeholder, and communities and civil society are involved. So I think for me, there are structures that exist and are different in different countries on how communities are involved at the design stage, because I think this question is really about engagement and leadership at design stage. And we also know that, COVID-19 put into sharp focus the fact that the role of communities and civil society in the response and also in the day-to-day running of health systems in terms of making sure it's equitable, making sure there's accountability, we cannot do without communities. I don't think there is a question about that. So I think the point is around engagement, about leadership in design and in responses and preparedness and prevention. It's really the extent to which we can expand the capabilities of communities to bring better leadership, to have a more inclusive space when it comes to actually contributing to the design stage. And many countries are putting the effort, but that needs to be expanded. And by expansion, we mean that there is space where communities come as equal partners to inform processes, to inform design, what is working at community level, what is not working, what are the best practices, what are personal experiences. And then in addition to that space, that's where we come in as equal partners, I think there's also importance to actually commit and support community and civil society participation in those processes. So just knowing how can we ensure that as communities come to these processes, they have the right technical support, there have been efforts on capacity strengthening, unpacking some of the language, unpacking some of the documents that then enables us to participate strongly as we bring our expertise, our experience, and our reflection. If you look at the civil society engagement mechanism for UHC, 2030 system that WACI Health and MSH are co-leading, some of the priorities we have identified there are the concept of leaving no one behind. The concept of leaving no one behind, meaning that we really urge and have been calling countries to identify populations in their countries that are most likely to be missed by health systems. We are also really talking about investments. How can we ensure that we are investing, that there is leadership, that there is political will to invest in systems in a sustainable manner? And that's where we talk about both external funding, but also more specifically country leadership in terms of investing in what the country priorities are. But also one thing we are learning from some of the global health agencies, we have the Global Fund, we have Gavi, we have the GFF. It's really also how to invest in community-led responses. When COVID-19 hits, countries that were able to bring communities on board, countries that showed resilience are those countries that were able to partner the national government, the external funders, plus community-led responses and cutting-edge science. So it's also about thinking about how can we ensure that investments are there. And why this is important is because then you bring communities to a point where they can contribute to the thinking, the design about primary health care at the country level. And I think two last points for me is when we talk about the UHC Day this year, the theme on building the world that we want, it's really important that it's not just consultations and engagement of communities in that process, but it's to really investigate what does community leadership mean, so that it's not just engagement. We are really talking about moving from engagement to really leadership, and we have to really unpack what does leadership of communities mean. Previous speakers have talked about trust. Trust is like we need to achieve trust for us to reclaim health as a public good, and for us to be better prepared, for us to strengthen health systems and how people access. And trust, I think primary health care is the best entry point for you to build trust, because primary health care brings you closer to the community. When we think about our continent, for example, where community health workers are the guardians of our continent, community health workers are really capable of helping us to build the trust. Community leadership, community-led response is very capable of helping us to build the trust within the health system. And that's something that as we go in the lead up to the high-level meeting on UHC next year at UNGA, we really need to see how do we elevate primary health care in our asks, in our outcome documents of the high-level meeting, because it really is one of the biggest leverage that we have to getting closer to UHC and making sure that everyone everywhere can access health services.
Rosemary, did we lose you?
Did I freeze?
Rosemary, there you are. Please continue. Sorry.
Oh, sorry. I don't know. I was I freeze. I was talking. I don't know.
Just about 10 seconds. Maybe just
okay.
A couple of sentences earlier. My apologies. Connection issues. It seems like.
Yes, it is. No, I was talking about primary health care as the best entry point for trust, the trust that we need as we work towards reclaiming health as a public good in our countries. But I was also talking about the opportunity we have with the high-level meeting on UHC coming up next year for us to actually position primary health care as a high priority and then ensure that we get commitments, at the country level on how we invest in primary health care and ensure that people everywhere can access health services without suffering financial risk. Thank you, Dan. Back to you.
Thank you, Rosemary. There are so many sound bites in your passionate remarks that I would love to just reflect deeply upon. But in particular, just really want to amplify your points about PHC being the best entry point to build trust, and community health workers being the guardian of the world, frankly. You said our continent, I would say the world. Thank you, Rosemary. Really inspiring remarks. I'm sure we'll come back to many of those in the Q&A. Having said that, let's move on to our fourth panelist, Diana Frymus. Diana, I'd like to talk a little bit about looking forward. Our colleagues thus far have talked about their work, and I know that you are the director of a newly launched collaborative. So with that regards, what does person-centered primary healthcare mean to USAID and for your programming? And what role specifically does the health workforce play in making primary healthcare effective? Thank you for joining us.
Thank you for the question, Dan. And first, it's really great to be here and to be joined by such esteemed colleagues on this panel and by the audience members joining us from around the world. This is such a timely opportunity to speak on this topic, especially given USAID's announcements on primary health care and the health workforce this week at the US-Africa Leaders Summit. I don't have to tell this audience how the COVID-19 pandemic undid global health development progress and dramatically weakening already fragile health systems and health workforces. And a renewed focus on primary health care is really an opportunity for USAID and the collective global health community partner countries to come together to reclaim that lost ground and ensure that we're delivering on improving person-centered primary health care and building resiliency for the future. I think this really also reinforces comments we've already heard this morning from other panelists. The evidence shows us that resilient primary healthcare-oriented health systems anchored by a robust, well-supported health workforce can improve life expectancy, it increases health equity, and ability to respond to disease outbreaks and emerging health threats. I think at USAID, we see that most health services that are supported across all of our global health platforms are delivered as components of primary health care. And our aim is, through our global health footprint, to advance integration to enable delivery of whole person-centered care across the individual's life stages, and how also we can further optimize the health system functions that are required to be able to enable that delivery as well, including, importantly, a strengthened health workforce. I will say, I think that this really also includes how we're really looking at strengthening different service models of delivery and how they enable really providing service continuum across distinct health needs, expanding access, of course, but also importantly, really working to consider more individual patient preference, which is so key, I think, to be able to provide equitable service provision. So at the Africa Leaders Summit on Tuesday, we announced 5 initial focus countries in Africa where we are committing to align and intensify our efforts. These include Cote d'Ivoire, Ghana, Kenya, Malawi, and Nigeria, where we will be working together with the US President's Malaria Initiative and also with PEPFAR, first in Malawi, to really harness our global health footprint and enhance coordination of investments, and importantly, work to demonstrate more cohesive, measurable improvements in primary healthcare outcomes. And as you noted, at USAID, we recently launched the Accelerating Primary Healthcare Collaborative, which we're really excited about to help guide these efforts. And this is a new model of how we're working in global health, bringing together subject matter experts from across our offices in the Global Health Bureau, and also representatives from our field missions. So we have staff from across 8 country missions currently working with us to really kind of harness our expertise and to develop a more cohesive primary healthcare approach for the agency that facilitates information exchange and learning across countries, technical integration, and really the aim for greater coordination to accelerate those impacts. I will note also, as part of those efforts, we are working on plans for monitoring our progress, building upon the existing monitoring frameworks that have been noted to today, and also working with other partners on how we can have more robust metric alignment at the country level as it relates to implementation and being able to have more cohesive understanding of the impact for PHC. You know, PHC is core to USAID work, and we're not starting from scratch, but we're rather building and accelerating our existing experience and efforts. So for example, you know, learning from our work in Nigeria, partnering with the Nigeria Pharmaceutical Council to strengthen capacity of proprietary medicine vendors and community pharmacists to screen and treat common childhood illnesses, improve access to family planning and referrals to other PHC services as needed. Or in Ghana, working with the National Health Insurance Agency and Ghana Health Service to define, cost, and implement, you know, health prevention promotion packages that includes community outreach for essential health purposes, but also now making sure that it includes treatment and retention best practices for ART treatment from the PEPFAR program. So within chosen focus countries, USAID plans to really more deliberately look across our funding streams. It's very much the how, like how can we really optimize what we're doing? You know, in alignment, of course, with national priorities and with other donor PHC investments. We want to ensure better coordination across health programming on cross-cutting areas of focus, importantly, the health workforce. And we also want to be able to identify existing gaps more cohesively at the level of primary healthcare, where targeted integration of services or programming can really contribute to the provision of better overall health for the population of our disease-specific work as well. You know, looking to advance, for example, introduction of mental health services, looking at cross-disease health literacy, referral support, how we're working to really advance decentralized drug delivery of integrated, you know, commodities. So key to these efforts is, I will say, is cohesively addressing a core source of fragility in countries, which is the lack of a strong health workforce, including community health workers, that is consistently paid, trained, supported, and coordinated. You know, the projected global health workforce gap is 10 million, 5.3 million in Africa, which underscores the need for increased focus on the health workforce. Importantly, those delivering primary health care and at the front line, prepared for future pandemic responses. You know, as we noted in the Africa Leaders Summit this week, the African continent shoulders a quarter of the global burden disease, faces more than 100 health emergencies per year, yet currently holds only 4% of the total of the global health workforce. And this really underscores the need for us to be coming together to accelerate our efforts to address the health workforce gap in Africa. And I'll say that at USAID, our PHC efforts are really, that is what we see as key to advancing the Biden administration Global Health Workforce Initiative priorities. The Health Worker Initiative was launched earlier this year. And we also had an announceable at the Africa Leaders Summit, specifically looking to focus more in Africa on this effort and kind of in a more cohesive way. And I'll say that key to this work is galvanizing partnerships to accelerate collective impact. So for the Health Workforce Initiative, that really also includes working in better coordination with regional partners, including Africa CDC, the Africa Union, WHO Afro, and for PHC. And I know we'll hear from Peter next, but USAID also is pleased to announce how our recently announced strengthened partnership with the Global Financing Facility to also accelerate primary healthcare. And again, we'll hear from Peter, but just to note that our plan is that in our PHC focused countries, we'll work more robustly with GFF to analyze our shared country investments, facilitate more joint technical assistance and convening of stakeholders. We're also hoping to be able to leverage new rounds of essential health grants and forthcoming rounds of additional financing and leveraging robust alignment pilot and tools from the GFF. So lastly, I do want to add that as part of our efforts to accelerate person-centered primary healthcare, USAID views country actors as critical for leading and strengthening systems and delivery of services and responsiveness to communities. You know, building those social accountability structures, increasing community ownership and engagement is really also critical for delivery of PHC. So we will be working closely with local governments and working to really help build capacity of local institutions and partners as part of our efforts to sustain our gains for PHC. So thank you so much, and I look forward to hearing more and having more dialogue with the audience.
Thank you so much, Diana. It's probably not surprising, but I'm incredibly excited for the new collaborative and really grateful for you joining us here today, and looking forward to learning and working with the collaborative more to advance this work. Having said that, thank you for the segue. We'll move on to Peter, our fifth and final panelist, Peter Hansen from GFF. Peter, building on the lessons learned to date by the GFF, how do you or how does the GFF see that we can ensure that efforts to strengthen primary health care are country-owned, data-driven, and perhaps most importantly, at scale? Thanks.
Thank you, Dan, and thank you, Diana. Good morning, good afternoon, and good evening, everyone. The GFF is currently supporting 36 countries to strengthen their primary healthcare systems. And the country engagement model that we use for that is very supportive of a country-led approach. It's a flexible, facilitative model, connects to high levels of leadership, including not only Ministry of Health, but also Ministry of Finance and other sectors as relevant. We work through country-led processes rather than parallel processes. And through this facilitative model, we support countries to conduct situation analysis and needs assessments, identify gaps and bottlenecks within their PHC systems, to prioritize reforms, to strengthen them, and then to develop theories of change and results frameworks to really test assumptions and create a basis for measuring progress over time. This work is documented in country-led investment cases that are used to align resources with those defined priorities. And these investment cases cover not only World Bank GFF financing, but all sources, including domestic resources and financing from other development partners. We support countries to conduct resource mapping to help unpack how much money is available from different sources and where, and to help support the alignment of those resources with the priorities that countries have defined within their investment cases. All of the GFF World Bank budgets, all the World Bank GFF resources are on budget and flow through public financial management systems, which further reinforces country leadership and helps to strengthen those systems. We also do support the development of leadership competencies through a country leadership program that we convene. And through an alignment working group that we convene, we do support countries to exchange and learn from each other. Is connected to an interministerial network where ministers of health and other leaders can exchange and learn about what really works to create the circumstances and the processes to strengthen the extent to which other development partners are aligning with their priorities. We use the one plan, one budget, one report framework to help inform that work. And I think another really important part of the model, which connects back to some important points that Rosemary and others said before as well, is that we do provide support to countries to strengthen their coordination platforms. I think a key part of a government's overall stewardship of the sector to make sure that these fora are inclusive for bringing stakeholders together, for dialogue, exchange, joint review of progress, mutual accountability, connecting to policy processes and various other decision-making resource allocation processes. Now, with regard to the second part of your question, Dan, around how do we make sure that efforts to strengthen PHC are data-driven, I would say that the GFF country engagement model is quite data intensive. We do make significant investment in strengthening the generation, analysis, and use of data through national systems. We don't support any parallel data collection processes or data use processes. The situation analysis and needs assessment that I mentioned earlier, which includes a gender and equity analysis, is really important for identifying those gaps and those bottlenecks, including who is being left behind and why. This is critical for helping to inform evidence-based prioritization of systems reform, for example, those related to strengthening health workforce or the organization of service delivery models. We do also provide support for regular progress reviews and use of data based on the theories of change and results frameworks that countries develop around their reforms. Again, not as part of a separate process, but through a government-led coordination mechanism linked to this inclusive fora that brings together other stakeholders and perspectives as well. This includes consideration of data on health financing, health systems reforms, service delivery, and population. We do see three key areas for improvements in making the model more strongly data-driven. And I think the partnership that we have discussed, which Diana has mentioned, between USAID and GFF, I think is one really critical way to do this. First and foremost, we see a lot of scope for strengthening PHC metrics and learning models. We see need both to increase the standardization of metrics, but also to ensure that these are not used in a one-size-fits-all manner, but rather are appropriately tailored and contextualized while providing the information that are needed on very specific reforms prioritized within a given setting, because we do know that the reforms that are prioritized from one setting to the next are highly variable. So we do need that tailored and adapted approach. This very much includes support for implementation research and evaluation on PHC strengthening efforts to address knowledge gaps and advance evidence on what really works to strengthen PHC systems and how. Two other key areas of strengthening, which I won't go into in detail in the interest of time, but I would like to mention briefly because I think they are very important, are strengthening gender responsive monitoring of the PHC reform agenda and also advancing rapid cycle monitoring. And maybe that term is a little bit jargony, but really what we refer to with that term is the effort to better align the cycles whereby countries generate, analyze, and use data with the real-world decision-making needs of leaders, policymakers, managers, frontline service providers at different levels of the system. And I think that's really addressing the problem statement that decision makers at all levels face, that there are often these terrible time lags between when data are available, what time periods they refer to. Policymakers are making decisions today, often based on data that are 7, 8, 9 years old, which obviously has very limited utility, especially in our very dynamic world. And then the third part of your question, Dan, which I'll address more briefly to keep the time here, is how do we ensure that these efforts to strengthen country-led systems operate at scale? The GFF really only operates at scale. The GFF resources are linked to larger amounts of World Bank financing, usually in the form of IDA. These resources are on budget, they operate through public financial management systems, and they do link to larger amounts of domestic resources. We, together with other partners, are actively advocating for and supporting processes to increase domestic resource allocation for health and for PHC specifically, and use of those resources that are allocated through effective budget execution and program implementation. Also advocating and supporting the strengthening of civil society engagement and private sector participation, all of which are very much needed for systemic change at scale. We support countries to take innovations and systems reforms that they experiment with in a smaller scale basis to scale through national systems, considering what is needed from a financing perspective, a governance and management perspective, what data information are needed, what implementation support is provided. And very briefly, I think one very important example of that is in Ghana, where the GFF, together with other partners, is supporting the effort to take to national scale the networks of practice reform, which Ghana has prioritized, which very much builds upon and is informed by the rigorous piloting that was incubated by USAID over a multi-year period. And I think it's a really great example of where that rigorous incubation and piloting by USAID has connected to a scaling lever like the GFF to help take those reforms to scale at national level. Diana has already mentioned the collaboration, which we are extremely excited about and see as a great opportunity to accelerate gains in PHC, including how we analyze and review PHC frameworks and country investment cases, looking at the specific reforms that are prioritized, how they're financed, how they're measured, Also how we work together to leverage new financing, including multiple financing instruments we have within the GFF, including essential health services grants and other financing, and how that links to larger amounts of World Bank financing, making sure we use that opportunity to really prioritize those funds toward the most impactful systems reforms for accelerating systems change, harmonization of metrics and learning models, providing joint TA and convening of stakeholders, and then leveraging the alignment pilot that is underway, the framework and the tools to really strengthen country leadership of an alignment process that brings together the financial resources, the technical inputs, and all forms of contributions from development partners to support a country-led effort to accelerate PHC change. I'll stop there and very much looking forward to the discussion ahead. Thanks.
Peter, thank you so much. A lot of that really resonates, but I won't comment. Why don't we actually utilize this as an opportunity to engage everyone who's joined us today. So first of all, my gratitude to the 5 panelists for making the time to join us today and for their inspiring opening remarks. And second of all, we will now be pivoting our conversation to a discussion. So first, please, strong encouragement to everyone to utilize the chat function to enter your questions. And several of our colleagues at MSH are in the background working to moderate the questions, and I will be including translation if needed for French and Spanish. Feel free to type in whichever language you'd like. And I will be sort of re-asking them to the panelists in hopefully creating somewhat of a cohesive order so we can carry the conversation forward. So with that being said, I'd like to start by amplifying a couple of points and questions made by Desalegn Amare and Eshutu from Ethiopia. I'm going to kind of combine some points here to highlight some themes. Eshetu writes, PHC has been a part of the MDGs and now the SDGs as a cornerstone of UHC. It's unfortunately been over 40 years since the Alma-Ata Declaration, but we still don't see PHC being achieved in many places around the world. Why do you think this is the case? Related to that, our other colleague writes, strategically, PHC is crucial to increase equitable access to health for all, but practically this may not be achievable in countries that have less infrastructure and areas with conflict and war. What new strategies and approaches could reach these people? And then a third commenter, I'm sorry, I'm pulling them up in real time, makes the same comment about resilient health systems and how these things are related. So ultimately, the themes bubbling up here are, we haven't made much progress, unfortunately, since Alma-Ata, and it's important to name that. Having said that, as we look forward, how can we ensure that, to use Rosemary's phrase, no one is left behind? I am happy to open this up to any of the panelists, but perhaps I can start with Jeff, given that you commented a little bit about this in terms of failures to date or lack of progress to date and looking to the future. And then we can have some other comments as well.
Thanks, Dan. I think this issue of resilience is really critical, and I think it loops back around to this issue of trust as well. And overall, from my perspective, I think in all health systems, in order for them to be prepared and effective for dealing with a crisis, and that means both responding to the crisis and making sure that the essential and routine healthcare functions that people need continue, it really means we need a stable, strong foundation at the base of our healthcare systems. And I think that really begins with the investment in things like we've heard about here already, competent health workforce, sufficient supplies, decent models of care in place so that the system has the ability to flex and adapt and respond to whatever the type of crisis is that a country or health system is facing.
Thanks, Jeff. And Rosemary, since I quoted you in the preamble, I feel like it's only fair to offer you the opportunity to comment on those multiple questions and comments. Any reactions?
Yeah, really good question, because we all want to see resilient health systems that are responding to people's needs. And I think we would know who we are leaving behind unless we are very intentional about identifying that, who is being left behind by our health systems, and then working to find a way of including them in the health system. There is a question around how different communities can bring points of view of the needs of especially people who are most likely to be left behind by health systems. What do they want? How do they want the health system to respond? What are the challenges? How can the health system meet them? One of the things we've been saying is that we do not necessarily have hard to reach communities. If you really want to reach communities, you will reach them. If you think about this analogy that we hear over and over, that in every small village in Africa, there is a Coca-Cola kiosk or whatever else from the private sector. So if we really need to reach communities with health services, we will do. What we have are hard to reach health services, not communities. How can we ensure that the health services are not hard to reach? I think that's something to think about. And the investment bit is really about everyone. It's the external partners coming to invest, but also very strongly. And this is also a message that the CSEM also puts across. It's also the domestic leadership, like how we can continue to support national governments to expand their capabilities for domestic investments. It's not an easy, straightforward answer and formula, but we have to think about how do we expand the revenue base of national government? Is it by streamlining how we collect, allocate, and account for taxes, for example, and how do we strengthen that as an example? So I think there are ways, and we have to work together, all constituencies, partners, national governments, community and civil society, private sector, to make sure that we actually ensure that the systems are resilient and sustainable as well.
Thank you very much, Rosemary. I'll certainly happy to have Peter or Diana or Serge make any comments if they would like to, and then we can move on to some other questions.
Yeah, this is Serge. Dan, can I quickly? I definitely made my opening remarks simple and at the human level. And I think when we say we didn't make sufficient progress since Almada, I would not fully agree with that, because we have made a lot of changes in the world since Almada. We have institutionalized community health workers in many countries. We have seen some significant reduction in child mortality during the MDG. So I think we made some progress, but obviously a lot of work still needs to happen and to be done. I think what we could do better is better exchanging experiences based on what we have achieved. There are very simple things: malaria treatment, and then childhood illnesses, management of those. There are things that's more complex on maybe newborn care or all of those services that needs higher level of skills and a stronger health system, and maybe higher skills of our providers. But there are many very simple things that we can do better. So I think we really need to share our experiences and build a system that will make those really sustainable, and look at our clients. If we see a mother with a sick child, if we just prescribe medication, antibiotics, does that lady have the means to get the drugs? Does that lady have the money? Does she know how to take care of to even get the child the medication you just gave her? So you really need to look at the person, and that to me is a person-centered primary healthcare. To look at our clients, what do I need to do for that person in front of me, and then take care of her and at her level, and then go forward with that. Thank you very much for the opportunity.
And
Thank
then
you,
maybe just add a point. Does that work?
please.
Yeah, I just wanted to say, building upon what Jeff said about, how COVID-19 really has underscored the need for us to ensure that health systems, at that foundational level have the capacity to quickly flex and respond. And I think that that also really demonstrates how that capacity for primary healthcare is really also part of global health security and our pandemic preparedness agendas. And I think that there's more recognition of that, but I think that really clear articulation of how these agendas kind of intersect will be really, really critical for that long-term sustainability.
Thank you, Diana. Really appreciate it. If I may, I'm actually going to ask you to start reacting to the next question, or actually set of questions. We've had quite a few questions in the chat around human resources for health, and I know that was a big thing that you featured in your remarks. In particular, community health workers, and some comments, including a healthcare professional from Morocco who notes that absenteeism issues may be particularly pronounced at the PHC level, and especially in remote areas where it's difficult to recruit and retain health workers. Given your past work, Diana, on HRH within the Office of HIV/AIDS and USAID more broadly, how are you seeing human resource needs impacting the underlying focus and the ultimate success of this new collaborative at USAID? And then I would certainly open it up to the other panelists, any other additional comments sort of on the implications of HRH shortages and how we need to prioritize this accordingly. Thanks.
Sure, that's a loaded question, so I'll do my best to answer it concisely. But I think that, there's been a global health workforce agenda for quite a long, over a decade. And I think just COVID-19 escalated the need and recognition of, not only the global shortage, but now we have this global burnout crisis, right? So I think that it's not only about the need for additional workers, but really, which I think a lot of us know, there needs to be stronger systems in place to support the available workforce that we have so that they are, we don't have a burnout issue and they are retained. And so I think that there's so much momentum right now, and it's really exciting. And I think that, on the implementation side for USAID, health workforce is core to everything that we do, right? If we don't have a strong health workforce, we cannot achieve, right, service delivery and our health goals. And I think that really across programs, we have to have recognition that we're all working with the one health workforce, right? It is the health workforce. We don't have vertical health workforce for, just malaria, HIV, and really kind of, I think that creates more of an opportunity of how we're really having that more cohesive investment to strengthen the health workforce that's delivering for all, right, services. And I think that importantly, that includes community health workers, but we want to ensure that we're also kind of looking at the multidisciplinary needs for the health workforce to deliver PHC. That includes community health workers with other frontline providers, nurses, midwives, doctors, and really how are we really enabling that team-based delivery, right? I feel like that's still, we all know that that's what has to happen, but I think we still need to really kind of see how we can really help enable that, and whether it starts from training, but also on the ground kind of efforts when folks are already in practice. I think importantly, there's a huge agenda around the need for formalization of a paid community health workforce, and that's so critical. And I think this topic is also one that cuts across sectors, right? I think that which is really exciting to see right now is that there's recognition not only in the health space, but I would also say, in the youth employment space, in the space related to women and economic recovery, and really kind of tying the threads across health and finance and labor, and seeing how investment also in community health workers and other women who already represent 70% of the health workforce is really key, not only to achieving health, but also kind of economic recovery and that triple return on investment, which is really exciting because I think it's bringing in new thinking and new players. And I think that, of course, we have to move the needle on ensuring that people are paid. It's key to retention. And decent work agenda. So a lot going on, but I think that kind of we're really working to kind of bring those different threads together in our efforts.
Thank you, Diana. Really appreciate it. If any of the other panelists want to comment on these issues of HRH as well, happy to open up the mic.
So I want to come in, and Dan has done a really great job in putting into perspective the role of community health workers, and not just community health workers, other cadres, nurses, midwives, doctors, and all. And especially in low and middle income countries, I think it's a question we really need to interrogate and think about the political leadership we need in terms of investing in health workforce, but also being creative. One of the questions I saw in the chat was asking, the participant was asking, how do you achieve that in a resource limited setting, for example, where you don't have a whole lot of money to actually, right now, given that we are still recovering from COVID-19, we are still paying a lot of debts, and many low and middle income countries experiencing debt crisis out of all these experiences. But there can be laws and policies that we can start somewhere. For example, remuneration of community health workers, putting a bill in parliament to ensure that we structure their pay and they are put on payroll is one of the things we can begin to do to work towards institutionalizing that. And some countries are doing that. The other thing we learned here in this conference is how just different countries were innovative. One of the speakers gave us a case study of how one of the countries, when COVID-19 hit, they closed all their medical schools and sent the medical students home. I mean, regardless of which year you were in your medical studies. And then the program was that they went back to the communities to actually begin training people who had retired, bringing them back to the workforce. Which wasn't bad, but we had all this expertise and skills that we could leverage on from medical students, working with them in a time of crisis to support, release some of the burden. So I think, like, in terms of better preparedness, thinking about the future, I think there's an area of thinking, how do we do with the resources and the capacity we have, even in medical schools, with the nurses, and how can the training and the practice actually converge somewhere?
Thank you very much, Rosemary. Your comments resonate greatly with me, but I won't answer. Anyone else, or we can bring some more questions in from the audience?
Dan, I'd make one additional comment about the workforce. I think, the burnout crisis that Diana referenced, I think, that's existed for a long time before COVID. And I think that begins with respect for primary health care and the work that those people do. And I know that personally as a family physician myself. I think, we need people who are trained to be able to care for people across the entire lifespan. There needs to be a valuable and respected career for those people in order to feel like that's a career path that they can pursue. And while I appreciate Diana's comment about the one workforce, I'm not sure it's actually true that we have one workforce that's all working on this same issue. I mean, I think we've developed, in a lot of ways, a very segmented workforce where we have CHWs, for instance, that are dedicated to one or just a few diseases in their work. And I think ultimately that doesn't lead to the kind of resilient health systems that we've talked about earlier. I think, PHCPI, I heard Serge reference all the progress that we've made globally in health improvements. And I think that's absolutely true. But I also think that, certainly over the years, and Dan, we've talked about this, that we've done it in a way that's grossly distorted health systems, and what's really left a very hollowed out foundation in many of these primary healthcare systems. And we need to find a better way to do that. And so I'm really heartened to hear about the new announcements from USAID and the ways of thinking about how we're going to be able to support frontline health workers and really deal with this issue of respect and burnout and having a career that's meaningful and that they can provide really resilient healthcare globally.
Great. Dan, do you mind if I respond?
Go right ahead, Dana. That's the whole point.
Yeah. And I think, what I mean by the one workforce is I think, and, I'm looking at this from an implementation lens where we often think about kind of what we need from health workers to deliver on certain areas of services, right? But not recognition that really there should be a foundational workforce, right? That is delivering all services and how we're really working to support that. I totally agree with you. This burnout issue has existed before COVID. I think we're just at a tipping point, right? And there's more recognition. And if we don't really tackle it now, like what will happen if we don't start to really address it now for the future? I think, in the community health worker space, yes, there is so much fragmentation. And I think we could talk about that for a whole other hour. But I think where we see and through the Global Health Worker Initiative with USG, it's like how we're really working to invest more in national cadres, but also recognizing that there may be other non-public, a role for non-public community cadres or other cadres that deliver specific tasks, but we need a better understanding of what that looks like and how we're aligning, I think, to those priorities. So a lot of work to do, and that's not an easy fix. But I think that importantly, there's recognition of the challenges.
Thanks so much, Diana. And just to amplify the points about burnout, I mean, as a health worker myself, 2020 has been more than a tipping point. And Jeff, I know you and I, Serge, you and I have talked a lot about this. We've lost a lot of colleagues, people that we never thought would move on to other work because it becomes untenable, it becomes unsustainable. And I think we talk about person-centered primary health care a lot, about the patients and communities we serve. We also have to always include that our providers are people too. And we have to build systems that account for and create sustainable, fulfilling careers and lifestyles for the providers, or else we will continue to struggle with these issues. But enough editorializing for me. No one wants to hear my voice. People came to hear you all. So having said that, we've had a couple of questions in the chat that I'm going to bring together, but especially one from Kofi about private sector engagement. And I think that that's maybe a theme that we haven't talked about much today, but I'd like to bring out and hear the panelists' thoughts. Kofi asks, in the opinion of the panelists, have we effectively leveraged the capacities of the private sector in the design and delivery of primary healthcare programs? And how could we potentially better utilize private sector entities? And Kofi offers the example of drug shops and private clinics to better access. Kofi says hard to reach communities. I would reference back to Rosemary's comment about maybe are there hard to reach communities or are there neglected communities? Maybe Serge, do you mind maybe offering some first remarks, and then other panelists can go on?
Yeah, absolutely. I think so far we didn't do a good job we haven't tapped all of the resources we had to in the private sector. I think there is still a lot of potential in the private sector. And when we talk about private sector, we tend to think of the big companies like Coca-Cola, like, the big telephone firms and aviation. But I think there is also a lot to tap in the smallest kind of private businesses in those rural areas, like the drug shops in rural areas, even transportation, little transportation companies for reference, counter referral system for the pregnant women or sick children to go to the health facilities. There are systems at the communities, and I think we didn't really tap into this at the level I would like to see, and there are resources that we need to do a better job on that. And I fully agree that that's an area we need to make some significant improvements in the next future. Thanks.
Thank you, Serge. Peter, Diana, I'd welcome any thoughts from your perspective on private sector engagement and how, if at all, that factors into priorities from GFF or USAID.
Thanks, Dan. Diana, would you like to go ahead?
Go ahead, Peter. I'll go after you.
Okay, thanks so much, Diana. Yeah, I think it's a really important question for sure. And I think, to me, there are some important process points that start with inclusion. And I think making sure that the private sector is not seen as an alien other, but a core part of an inclusive process, right? So that there is opportunity for participation, for engagement, being part of regular coordination fora, being part of policy processes, I think is very, very important for enabling their role and their contributions to be better understood and to contribute to the overall thinking and work within the sector. And then I think certainly when it comes to public sector functions that are important for engaging the private sector in a strategic and helpful way that can advance health goals, I think there's a great deal to be done. I think a number of countries do have very well thought out strategies for how they engage the private sector in different ways to advance mutual health goals that are defined for the sector and for society more broadly. I think a number of countries do still have gaps in those strategies and could benefit from strengthening their own mechanisms for engagement, the strategies for how and where they engage and so forth. And I think there are many very good examples of innovations in different contexts that have been very helpful in leveraging what the private sector has to offer to advance health goals. And I think in particular, where governments have been able to strategically purchase services from the private sector in a way which is on strategy, in a way which leverages efficiencies, the ability of the private sector to reach different populations. Sometimes that may be adolescents, sometimes that may be urban poor or other marginalized populations that the public sector is not doing a very good job of reaching, or that may not, or for which they may have challenges in reaching them efficiently and consistently. I think that can be a very, very effective way for strengthening a system and improving its ability to deliver high quality services to populations that need them in advance health goals. Thanks.
Thanks, Peter. Others?
Yeah, I would just say, I think we can't really talk about equity without the private sector as part of the PHC system. I mean, some of our most marginalized and vulnerable populations access services in the private sector, whether it be, formal private sector, facilities, or also, services that are supported by community service organizations, right, or faith-based organizations. So, and I think that, there are sustainability challenges, of course, for some of those models that have been supported by donors. But I think that it's also recognizing that there are preferences, right, for where people access services. And I think really needing to understand preferences as part of advancing PHC. And that's where kind of the voice of whether it be communities, but also really understanding kind of preference and kind of barriers to access as well are so important for designing models that really cater to all.
Dan, can I add one other comment on this?
Absolutely.
It is someone with, colleagues around the world who are working in the private sector doing primary healthcare delivery. I think there's a really critical issue that we haven't given enough attention to. I know at PHCPI, our data doesn't include great information on the private sector, apart perhaps from a lot of the progression model work that you did, Dan, when you were at RNA Labs. I think globally, my work in Southeast Asia, there's a robust private sector, and it's really meeting a need for people that the public sector isn't meeting. And so we need to recognize where those deficits are, and then B, support the people who are filling those needs. And I think there's ways to integrate them into a better public health approach to primary health care. Our work in Vietnam, for example, one of the things they recognized was that a lot of specialists, because of the lack of competent providers, were providing primary health care out of their private clinics. And so they required that those specialists who want to provide generalized primary health care get special limited training, but at least some training on how to provide effective, comprehensive primary health care. Barbara Starfield showed that when there's more specialists, mortality actually goes up. And I think the reason that is because they're trying to cover primary health care in ways that they haven't been trained to do. And so, working with government, with private sector to try and put some of these regulations in place so that we can support those providers and at the same time make sure that people are accessing them or getting the kind of services they need is critical. And I think that goes all the way down to every type of frontline health provider. And that includes people like the drug shops. There's certainly ways that we could put in place limited training to help them understand those core primary care functions and how they contribute to them.
Thank you so much, Jeff, and to everyone for all the comments and questions. I regret to say that we are due to end this webinar in 2 minutes, and I want to be respectful of everyone's time, especially given that for some of our colleagues here, it's quite late evening. So I will be wrapping up, and I'd like to first start by thanking our 5 amazing panelists today. It's been a privilege to have you here with us today to learn from your experiences and wisdom, and to think together about how we can do better for the future. Secondly, significant gratitude to our interpreters and the many people in the background on logistics who have supported today's session to make it go so smoothly, both in terms of planning and implementation. And thirdly, and finally, my gratitude to all of you who joined us today. We are unquestionably at a crossroads as we think about the future of the SDGs. There is a deep amount of skepticism from many people around the world that we will succeed in accomplishing the SDGs, that we have the ability to truly accomplish health for all. The past few years have been very difficult, and there are many people who have a lot of data to show that we have lost ground, that we are not on track. There have been a lot of conversations about that recently. I suspect many of you have been a part of them or led them. While acknowledging these challenges, I humbly disagree. I not only believe that it's possible, I believe we have to succeed. And as Jeff said, I personally think it's time to put to bed the mythology that primary healthcare is too complex, it's too expensive, it's not easy to understand, it's just kind of messy. So we can't do that. I think that has to end. And I think we have the data to show it. And as Rosemary said, there's no hard to reach communities in terms of primary healthcare. There's just an unwillingness to reach them. And if Coca-Cola can do it, I think we all should be able to do it as well. Serge's story reminds us of why, reminds us that this is literally people. These are human beings. These are our colleagues. These are our friends. These are our mothers. These are our children. And if that is not a reason enough to reach these communities and to deliver on these goals, then I don't really know what is. And I would bring back to the skepticism the fact that if Diana and Peter are here today representing their own institutions and showing how we as a global advocacy community have been able to move the needle in terms of the funding agendas and the priorities, I would say not only is it possible, I would say we are actively showing progress right now. And that is, in my mind, a positive omen for the future. But we still have a long way to go, and we must. Otherwise, we will fail, and the skeptics will be right. And on this UHC Day in 2022, I have no interest in letting the skeptics prove us wrong. So thank you all for joining us today. And more importantly, thank you for helping to lead this global movement to do better for our future. I wish everyone a happy UHC Day 2022. Cheers to the future to come. Thank you and have a very nice evening.
Thank you so much, everyone. And happy holidays, everyone.
Happy holidays.
Thank you very much. Bye.
Cheers.
Good New Year.